Hello, this is Chapter 1, Lecture Video Part 2. So we're going to pick up where we left off from the first video. Still focusing on treatment models, we are going to take a minute to talk about old treatment models versus new treatment models. So treatment models of the past traditionally focused on abstinence being the way to go. So abstinence meaning that you are completely staying away from your substance of use. So whether it be alcohol or drugs, you're totally staying away from it. Total abstinence was kind of a focus of traditional treatment programs back in the day. In outpatient treatment that I used to work in, we would drug test people, and I can't recall exactly, but I think it was like the second or third drug test. If you were to fail that, then you could potentially be kicked out of the program. So a lot of treatment programs focused on this traditional abstinence model. Since then, we have kind of come into a new perspective of things, and that being this harm reduction model. The harm reduction model, you will hear the authors talk about this several times throughout reading the textbook, but this harm reduction model is a way to help a person who is struggling with addiction to lessen their addiction. So not completely focusing on abstinence, but you're lessening that addiction. So the harm reduction model is a strengths-based approach. The goal is not abstinence. The goal is to work with the client where the client is, to work on what their immediate goals might be, to try to cut back on using or to reduce their risk for disease or different things like that. You're reducing that behavior, you're reducing that use, you're reducing that addiction. It is a more individualized approach when we talk about the harm reduction model. And the authors can find strengths in both the traditional models as well as the harm reduction models. So there are positives to both approaches. Now, when you're working with someone in addiction, and we talked earlier in the first lecture video about kind of like that concept of that I'm never going to use again. I'm never going to do this. So like those big, bold terms that can scare a person away. If you're having someone who's just coming into treatment and you're using those terms, it can be a scary thing. So if you approach a person with this harm reduction approach and you talk to someone and you say, okay, well, we're going to try to reduce, you're using 7 days a week, maybe we'll try to use 6 days a week, and we'll kind of lessen it a little bit by that. It makes more smaller achievable goals for a person to kind of work towards that bigger goal that they have. So there are definitely strengths in both models. As far as, total abstinence, obviously you're refraining from the use of the substance. You're free from your addiction. And the harm reduction being is that you're reducing something so that you're working towards that goal of total abstinence, hopefully. Harm reduction is not about doing what is best. It's about doing whatever is working for the client. So you're meeting the client where the client is. That is like a social work principle, is you want to work with the client where that client is. If you set expectations for a client, it might be unlikely that they could achieve those expectations. So you're working with the client where the client is. Another form of harm reduction might be substituting a less harmful drug in place of the drug that they are using. So for example, heroin. Heroin, you've probably heard that in the news, or, that's a common drug that we hear in our society today. So a person may not be using heroin, they may be using Suboxone or be using methadone. We're supporting that lesser of the two evils. So heroin is a very dangerous drug. You don't know what you're getting. The drug dealer could cut it with something else. So when you get Suboxone or you get methadone, it's a safer, less harmful approach to using heroin, and then hopefully you can wean a person off the Suboxone or the methadone. I would say that more likely you're going to see harm reduction in drug use more so than alcohol use. Not saying that it doesn't happen with alcoholics as well. You can use it with any drug or any substance. You could even use it with any addiction. However, throughout the textbook, they reference a lot of different things that I think kind of focus more on drug use and different things like that, like the needle exchange programs and different things. Kind of going backwards a little bit, we're going to talk a little bit about some research, some past research studies, and then we'll move into some more recent research studies. So I cannot talk today. Some past research studies kind of talk about evidence-based practices and how treatment programs should be using evidence-based treatment practices to increase performance standards, improve the cost effectiveness of different treatment programs. So their primary goal is looking for how can this treatment program be effective for someone. How can we justify that these treatment programs are helping people in addiction? So that's kind of where a lot of these research studies were aimed to help prove the effectiveness of this. It can quickly become a numbers game when we talk about treatment instead of a quality game. And unfortunately, that can be a scary thing if we look more so at numbers than quality. But, hopefully with this harm reduction model and focus on, more individualized treatment, we're increasing that quality game versus that numbers game. Treatment effectiveness can be measured through the evaluation improvement in terms of reduced healthcare needs, less dependence, lowered crime rates, success in employment, family functioning, and mental health. So we're measuring these different aspects on how they are improving, because when you have a person in addiction, their family functioning may be non-existent or not as good as it once was. You're losing trust, you're losing relationships, you might be losing your job, so there's not as much success in employment. Higher crime rates because you're stealing to get your money to get your drugs, or you're stealing to get your drugs, or different things like that, or you're selling drugs, or selling yourself to get your drugs. So the National Survey on Drug Use and Health says that about 3% of the population report that they are in trouble with drugs and need treatment. The population is a little under 10 million, and only 18% of those say that they need help, will actually get the help that they need. And for reasons such as maybe lack of access to treatment or transportation, or maybe just not motivated or not ready to go to treatment yet. A lot of funding goes to hospital care, jails, and courts, or emergency type treatment to help save. So we've heard of Narcan. So Narcan is a drug that can be administered to someone who is overdosing from heroin or opiate use. And Narcan can kind of bring them back to life, so to speak. Project Match in 1997 had 2,000 patients to study, and it talked about different types of treatment that worked best for those particular patients. So we understand that we have this population of people, and there is a need for addiction treatment. So how are we going to help them? So Project Match had this study where they reviewed it to kind of help, again, prove that evidence-based treatment that we're looking for. And it focused on 3 different types of treatment. So there was conventional 12-step based treatment, cognitive treatment, and motivational enhancement therapy. So I'm going to review a little bit out of each of those for your understanding. So all was one-on-one treatment. There was no group therapy. So there could have been, group therapy, but they chose not to do group therapy. It was all one-on-one sessions. 12-step was 12 sessions, and the counselors used this design to explain the basic principles of Alcoholics Anonymous. Alcoholics Anonymous focuses on alcoholism as a disease. So it's progressive and it will kill you if it is not cured. You are powerless over alcohol. You must rely on a higher power, humility, and surrender, and attend AA meetings. So that was the focus of these 12-step sessions, the 12 sessions that they had for that. The cognitive therapy approach was also 12 sessions. It focused on relapse prevention. So it focused on how the patient or client viewed things. In the first lecture video, we talked a little bit about those irrational thoughts and that cognitive processing. So that's kind of what this therapy focused on, is helping that person change their thought process to be a more positive one, or be one that is more functional, should I say. It also utilized social skills training and stress management. So the way we view the world and our behavior are related. So if we reduce the stress or reduce those negative thoughts, we will reduce the use. It's kind of how we're finding alternatives to using would be that therapy. Motivational enhancement therapy was only 4 sessions. So 12-step and cognitive were both 12, and motivational enhancement was only 4 sessions. So it was shorter of the 2. This type of therapy was associated with the harm reduction model, the client-centered techniques where the therapist assesses the level of the client's motivation for change and doesn't fight the client, but kind of rolls with that resistance. Because again, not everybody that walks in the door is ready to get help or ready to get their treatment. So the results of these 3 therapies were 1 and 3 years after they had treatment. So patients did well in all 3 treatments. There was not one that did better than the other. Those who participated in 12-step were more likely to remain abstinent, while others reduced the days of use. So we had that traditional approach to treatment, which was total abstinence, and kind of like this new and improved way of looking at treatment, which was the harm reduction model. So 12-steppers are likely to remain abstinent, while cognitive or motivational enhancement were able to reduce their use. Those with severe addictions did better with total abstinence. They couldn't handle just moderate drinking. So once you're so far into your addiction, cutting back may not be an option for you, is what this study had proved for us. Individuals with strong religious beliefs did better with the 12-step program. Again, we're focusing on that spiritual aspect of recovery. Clients with low motivation did better with motivational enhancement therapy, because if I'm not motivated, that's increasing my motivation for it. Males did worse than females regardless of the method, as did those with behavioral health issues. So males weren't as likely to be successful with these different treatment programs as females were. However, I'm sure there were still successful males. I don't have a number for that. There were some limits to this study, however. They did not have a no treatment group, so you did one of the 3. There was there was nothing to compare it to as far as no treatment at all. When we talked in the first lecture video, we talked about recovery on your own. There was nothing like that in this study. What else did I say for this? This was a study of those with serious alcohol problems, so it didn't really focus on drugs, just severe alcohol problems. Government is no longer focused on total abstinence as the goal, but rather on improvement, so that harm reduction model as well. There was another study that was conducted in 1983, Valent. I know I always mispronounce that last name. It was a longitudinal study over 40 years, and it just focused on males. This study concluded that factors associated with recovery in middle age were personal willpower, active church membership, or other group membership such as AA, stable marital relationships, and hobbies. Those who have a relative with a drinking problem significantly increase the risk of alcohol abuse without the person having to have been living in the home with them. There was a 50-year study found that over a lifetime, sustained recovery required at least 2 of the following experiences. So in order for a person to be successful and be sustained over a lifetime period, they had to have 2 of these experiences. So that would be some sort of compulsory supervision or a painful alcohol-related event, finding a substitute dependence such as AA, a new stable relationship, and a religious conversion. Over 50% recovered from drinking at some point in their lives. And research says that once someone starts drinking, they do have a good chance at recovering, but it's going to take work. It's not going to be an easy fix. It's not something you just snap your fingers and, oh, I'm cured. I'm no longer an alcoholic. I'm no longer, using drugs. More recent research studies that are important to kind of note in how treatment has been affected is Dawson in 2005, the National Institute on Alcohol Abuse and Alcoholism. 1/3 of the people previously diagnosed with alcoholism matured out of their dependence, and 1/8 abstained, and 1/6 became moderate drinkers. So people may have started younger, but they matured out of their addiction. Interesting concept. So as you get older with time, those things kind of helped them no longer be addicted. And the more alcohol they use, the less likely they were to recover. So again, maybe there is a concept on measuring severeness of an addiction. So if it's something you're only using once or twice versus you're using every day, all day, every day kind of a thing. As if there's a scale, if you will. Hester and Miller, 2003, they did a review of hundreds of different studies. So they found that there's no single superior approach to treatment for everyone. Again, focusing on that there is not one specific way to work with everybody. You have to kind of do that individualized approach. Different people respond better to different approaches. There were 47 different treatment modalities that were tested. Top scores for effectiveness were for brief intervention, motivational enhancement, the use of medications such as naltrexone, and cognitive therapy. The lowest rankings were found for the use of educational tapes, lectures, and films, confrontational type therapies, and 12-step facilitation. So I have to kind of throw something in there. When I worked in drug and alcohol outpatient treatment, again, I told you about how I worked with outpatient groups, and I also did intensive outpatient therapy. So outpatient really only met once a week, and intensive outpatient was 3 times a week. So when I would do my IOP groups, the intensive outpatient groups, you're seeing these people 3 times a week, 2 to 3 hours a group a day. And sometimes you're just like, I need something new to add to it. So every once in a while I would throw in videos because they would kind of get sick of talking themselves every once in a while. So I would throw in these videos, but these videos, oh man, they were literally VHS tapes. So I felt that they didn't get as much from these videos because they were so outdated. Because if you think about it, okay, we have VHS tapes and we're way past that in like DVD, MP3, streaming type things. You can imagine that the material might still be like the concept is still the same. There's still drugs, there's still an addiction, there's still an issue. However, so much has changed since then. Going back to the beginning of this video where we talked about, traditional value or traditional treatment effectiveness was total abstinence, and then we moved into this harm reduction model. So some of those VHS tapes were pretty outdated, but needless to say, something different, I guess, we added to that treatment group, but I had to comment on that. So the educational tapes weren't always good, but confrontational therapies too, I find that it depends on what type of population you're working with. If you're working with someone who is court ordered or mandated there and you're confrontational with them, they're going to be confrontational back with you. Now, there is a time and a place where you might have to be a little bit more assertive or be able to be confrontive to someone who, may not be being honest about their use, but, different types of confrontational therapies, I could see that not being a very good mix for everybody. But for some, it may work better. So again, that, not everybody works with one particular treatment. And 12-step facilitation, again, you're working with people who have your focus is like that higher power, that spirituality thing. And not everybody is into that. Not everybody wants to focus on that spiritual or that higher power thing. So again, that treatment may not work for everybody. And I'm going to skip over that one. So some treatment trends that I wanted to kind of point out to you would be that, the field of substance abuse is always changing. So we, not only is it changing in treatment trends, like abstinence to harm reduction, our drugs are changing. I shouldn't say changing, but we see patterns where certain drugs become more common at certain times, different time periods, or different things. Although there are new drugs that come up all the time, like something like crocodile. I'll talk about that when we get to the drugs chapter. Or bath salts. I'm sure you've heard about bath salts, different things like that. So always evolving with new substances, always evolving with new people using or who it's affecting, and new treatment approaches and new populations to treat. There's unfortunately an increase in misuse of prescription painkillers. There's an increase in use in alcohol. There's an increase in use in other drugs. With the increase in misuse of prescription painkillers, it resulted in 16,000 people dying from overdoses in 2013. Heroin overdose deaths were 8,000 in 2013. So those are some big numbers of people that are overdosing in deaths in 2013. Abstinence continues to be the norm in the 14,000 substance abuse facilities in the United States. Harm reduction isn't necessarily catching on in the United States. So that's something important to note on too. So we are trying to move towards this harm reduction model, but it isn't quite fast catching on in the United States. Don't get me wrong, there are some states that are more likely to catch on to that harm reduction model than others, but it is slowly catching on. So I wanted to point those out. Those are some important things that may or may not be on a quiz. More outpatient treatment is being funded than residential type treatment. So when we talk about outpatient treatment is where you actually stay in your home and you go to a treatment facility for a few hours and you get to come home. Residential treatment is where you actually stay there and you're staying overnight at these places. Inpatient stays are also shortening, unfortunately. A little personal input for that one is I think that that's a bad idea. I think inpatient is great because you're actually removing a person from that environmental factor and you're putting them somewhere so that they can get the help that they need. But if you're shortening that stay, then maybe they aren't quite ready to kind of go back and face the drug dealer who lives on the corner of their street, or they're not ready to, be around the family that's nagging them about their past use or that they stole $500 from them or whatever that situation might be. So, yes, I understand that it's just getting to be too much, but it could also be a bad thing too, because you're not funding that person to be able to kind of effectively remove them and effectively get the treatment that they need. We talked about the use of outdated techniques and attitudes are issues that negatively impact services. The use of VHS tapes. 12-step facilitation is used in 74% of treatment centers. Trauma-related therapy is provided in 71% of treatment centers, and 88% use motivational interviewing strategies in combination with traditional approaches. Every case is different. It is best to individualize. I can't stress that enough. Case management is also becoming more popular. Case management is where you're going to have a specific person that can kind of help connect you to some of those resources or outsourcing in the community and different things like that. So case management is becoming a more popular thing. Public opinion is shifting because more people know someone with substance abuse, therefore they are being more optimistic about recovery. There will always be resistance to change. There will always be someone who doesn't like the changes or doesn't want to change or doesn't want to get better. There's resistance across. We could talk about that from many different angles, whether it be from a treatment standpoint or a political standpoint with that. Some other things to kind of note before we close out chapter 1. The majority of clients in the United States are forced into treatment in some way, shape, or form. So that's what you get the term mandated clients. So mandated clients are people that are court-ordered into treatment. America's war on drugs want to move toward rehabilitation. However, there is still a lot of support for harsh sentencing practices. So we're still kind of having this war on drugs currently. Some things to mention, I had talked about in harm reduction not catching on in the United States as much, but California is one of those states where the harm reduction model is catching on rather quickly. San Francisco in 2001 was the first United States city to adopt harm reduction models as its official policy. They had such things called wet houses or apartments set up for formerly homeless people with serious alcohol problems. They were allowed to drink in these establishments. So, you could see where people would be resistant to that. Well, okay, why are we providing them a home where they can go drink? Like, are we helping them or are we, promoting their continued use? However, you figure if you're taking the homeless person off the street, it might reduce the crime rate. You're more likely to maybe get them to be able to talk to them about different treatment options or getting clean or getting better. It reduces the cost of hospitalizations, incarceration, detox, and there's a reported decrease in drinking levels. I mean, I often think about this. Think about when you were a child and you were growing up. If mom and dad told you no about something, you might be more likely to do it because they told you no and you want to rebel against them. So is that where this harm reduction model comes in? If somebody backwards for a second. That abstinence thing is somebody's telling you no, so you're more likely to rebel against it. But with the harm reduction model is, okay, well, it's okay if you reduce it. So is that actually psychologically doing something for someone to say, okay, well, if I'm allowed to do it, it doesn't seem as appealing to me? I don't know. One of the many questions we could ask about this theory. Also, the state of California passed Proposition 36 in 2000. This was treatment over incarceration law, which sends low-level drug offenders to treatment rather than prison, which would be a good thing. From the data, 130,000 individuals who participated in the program. Over 60,000 people completed the program by the 4th year and avoided prison. Over the 5-year review of this program, California had saved $1.4 billion. So that's a lot of money saved rather than just shipping somebody off to prison. Something to think about. So it seems that California is catching on to the harm reduction model for alcohol use more so than for drug use. But The purpose being is that some way, shape, or form, we need to bridge the gap between the research and the practice. So how we could do this is kind of, being aware of these different past research studies, being aware of different things that we've tried before in the past that maybe didn't work, being aware of things that we have tried in the past that have worked, and also something that we'll kind of touch upon more so when we talk about brain chemistry and stuff like that is funding for more research studies, and funding research studies that aim to use neural imaging technology to observe how various therapies affect addicted brains. So this might help prove that treatment does work for people. So if we're doing different brain scans and we're viewing these different things, we're proving that, okay, so we have this therapy might work with this person because you can actually see the brain difference, and you can actually see the brain chemistry difference based off of this neural imaging. So this might be the start of helping to provide more funding for treatment programs, more funding for research to help people in addiction. I'll leave you on that note there. So the next video, we will move into chapter 2. So stay tuned.